Hello, good afternoon. I'm Chris from Alzheimer Europe, and it gives me great pleasure to welcome you to this parallel session on technology in the context of dementia. We have a panel of 4 excellent speakers who are going to introduce us to different studies revolving around the topic of technology use in the research field of dementia. Our first speaker is Ioulietta Lazarou from Greece. She's going to talk about the WADA-AD study, an innovative medicines initiative funded research project, and especially about the investigation of the impact of a real domestic smart home environment in people with cognitive impairment as part of their Tier 3 study, which was a usability study. Please, thank you.
So, yes, as Chris mentioned, the aim of the Tier 3 study was to introduce a more holistic and preventive monitoring for people with cognitive impairment, and especially at preclinical stages, and healthy controlled individuals in a real living smart home environment. This smart home environment, the CERTH ITI smart home as we call it, entails the deployment of different IoT sensors technology. In order to test whether this can be a feasible approach for monitoring and testing of people with dementia and healthy elders, we conducted a feasibility study with 13 cognitively healthy controls over 60 years old, and we gave them the opportunity to come for a daily visit or to stay also overnight. We received also approvals from the CERTH, Scientific Committee of Alzheimer, Greek Alzheimer Association as well. So here is the CERTH ITI Smart Home. As you can see, it's a rapid prototyping. It's a near zero energy building that has been constructed and developed in Greece, in Thessaloniki. So it entails different kind of technologies inside. As you can see, it simulates a real domestic environment. So it has a kitchen, living room, a bedroom, so the participant can stay and feels like he's at home. It's a 2-floor building as well. It's the first smart home in Greece, located in premises at CERTH ITI. So then we selected particular sensors after discussion with the rest of the consortium, and after conducting several focus groups, we decided what kind of sensors and IoT technologies will be used in order to test and capture changes in the activities of daily living, in physical activity and sleep, as well as in changes that occur in brain activity. So we choose sensors that are installed at in electrical appliances, the wall plugs. Motion sensors capture the presence of a person in a particular area. Door sensors, panic button in cases of emergency, the float sensor, 2 wearable sensors, Fitbit and Empatica, to capture, as we said before, physical activity, sleep, heart rate, and GSR. And finally, a portable EEG, the Muse, which shows us brain activation in different kind of resting states or cognitive exercises. So we installed the sensors in different rooms. So we installed the motion sensor in every room to monitor the presence of a person. Smart plugs, as we said before, in electrical appliances to monitor the ADLs and how they perform particular activities such as cooking. Float sensors in sink and flush. Door sensors in windows and doors. And the panic buttons, because we speak about elderly population. So we need to be sure that in cases of emergency they can call us, because we were not all the time in the smart home as researchers, but we gave them some time to stay all alone and perform all the activities all alone as they would do if they were at their homes. So here is a study protocol that we constructed in order to test this kind of activities. So there were two options, as we initially mentioned. The participant could come for a day, for a daily visit, or they could also stay at night. So they had to perform 5 tasks, and one task was optional. And the tasks were about to monitor ADLs, physical activity, cognitive exercises, and also some tasks that can be helpful for them to be relaxed. So here are the four tasks that monitor ADLs. We gave to the participant particular instructions of how to perform each task. For instance, turn on the coffee machine, then open the cupboard, take the coffee, then turn off the machine. So there were particular instructions and very detailed program and schedule about what they had to perform. This was because we wanted to somehow capture every movement, let's say, in every step of how they perform in order to analyze the result and have a better view about people of early stages or later stages as well. So these tasks were entailed a coffee preparation, preparing of a hot meal, preparing a tea, and preparing of a cold meal or breakfast in the morning for those that stayed overnight. The other two tasks were about monitoring physical activity. So the participants performed some easy, let's say, yoga exercises, and they wear the Fitbit and Empatica wearables. And then we also gave the Muse EEG and performed some relaxation activities, the mindfulness-based stress reduction and the Kirtan meditation tasks. The one is more a passive meditation task, and the other one is a more active meditation exercise. So the results of the feasibility study, because now we present the results of the feasibility study that we conducted of the healthy controls. We administered some questionnaires in order to assess their acceptance, their satisfaction about the whole procedure, because it's a very novel and it's a combination of different sensors and a very extensive protocol, which is tested for the first time. So we collected the requirements and their preferences and how they found the whole study. So after administering the quest and SUS questionnaire, we found that the participants were very satisfied with the sensors, the whole procedure. Actually, they find it very novel and very different. They were not actually feeling as they are being monitored or as they're being tested, as they instead of being in the hospital, they would prefer to take part in such activities because it's fun and very helpful for them. So as we found in the system usability scale test, all participants noted a mean score over 90, which is a very high score, and shows the effective that performing activities and testing at a smart home environment is effective, efficient, and very easy for them to use. The sensors were not obtrusive or were not stressful for them. So from the questionnaire, we found that they are very satisfied to use wearable sensor in order to being tested. And their overall experience were very positive. They felt very comfortable in conducting such activities in order to find if they are at early stages or later ones. And here we have also some feedback from them. As we can see, they are very excited, actually. It was a very interesting to see them being happy, actually, after being tested, because from our experience in outpatient clinics, we see that they are very much stressed and very anxious about the results, but here they found it very helpful and interesting. So that's from now, and we hope to have also some results from the rest of the group soon. I'm okay. I'm on time?
You're perfectly on time. Thank you very much. There is a lot of time for questions. Please, Alexander. Do we have a mic?
Did the smart home technology and the monitoring, in which respect did it help or assist the participants? That's not clear to me.
Yes, actually, because from the platform that we collect the data, the visualizations that occur can be present also to their caregiver or to the people in a more simplistic way. So they can have also a view of what they did during the day, actually. So they can see that they slept well or not, or how they performed particular activities, if they had an increased heart rate during the day, and it's not a subjective, let's say, opinion that they have increased or reduced heart rates.
So it was not the case that, for example, for preparing tea, the participant needed to open the cupboard, and if he did not open the cupboard would say, "Open me, open me, open me."
No, no. No, but he could see that he opened several times the cupboard, so that is something that he has to look at it, because he repeats several steps during the day, and this is a clue that something is not going so well. Yeah.
Hello. I wonder why you use so many different tools. My husband has dementia, and he uses Alexa, and with Alexa, he can do a lot of the tasks that you've got using different kind of technologies. And actually, to have all the different technologies is confusing in itself, whereas you can, use one specific tool that could do a lot of that. But the other thing is, where's the person-centeredness? Were all the participants doing the same things at the same time, or did they have an essential lifestyle plan or something that they could fit in to say what time they wanted their cup of tea or what time they wanted their lunch, or they could program that in themselves? I just wondered, so have you thought about it?
Yes. So for your first question, I have not worked with Alexa, but I'm aware a little bit of this kind of technology. Actually, we try to use sensors that are best and more sensitive for a particular functional domain. So we use some plug sensors and some presence sensors to monitor ADLs. So I think Alexa cannot capture all this stuff and has a proper and objective information about sleep, about cooking, about all these ones.
It can in lots of ways, because it can actually, you can ask it to give you a recipe, you can ask it to set timers, you can do lots of things around. My main concern is that there's so many different, you work with a group of people with dementia, but once you've got working with a group of people with dementia, using all those different tools, you have to learn.
But it's a passive monitoring. They don't have to switch on or switch off some sensors. It's a passive monitoring of capturing activities of daily living, so they don't have to turn on or turn off the sensors. They have to just to use the appliances or perform.
Is there agency and autonomy in that?
It's autonomous system because it has not to.
Agency and autonomy for the person with dementia.
Yes, it's not an obtrusive system, actually, and that's why we're testing for a feasibility aspect. Yes, it's a good question. And also for your second one about the program. Yes, in order to capture for the study, actually, in order to capture how they perform, we ask them to follow a particular program, as I show you in the third slide. There was a specific time schedule. So as for us to be able to see exactly during the day what they did and monitor the activity. But of course, if we install this system at their home, we could not ask them to perform these activities in particular times. Yes, please. Yes, we conducted focus groups, and we also engaged people with dementia and their caregivers, and we collected their requirements. We also asked some healthcare professionals. So we have also a published study where we demonstrate all the results in collaboration with Alzheimer Europe, and why we selected this kind of sensors for particular functional domains in order to be monitored. So in order to monitor physical activity and sleep, we concluded that Fitbit was a more proper sensor for it. In order to monitor ADLs, we should use this kind of sensors. So we categorized the functional domains firstly, and then we selected which kind of sensor will be used for each particular domain. Yeah, actually, this study is a part of the large radar AD project, where it has other two tiers. The first one is a big one, including around 200 people being monitored with wearable sensors. And the second tier is about monitoring people at their homes with some kind of sensors that I presented also. So the study here at the Smart Home, which is the Tier 3 study, as the title says, is about to see if a combination of it can be feasible and can produce some interesting results and can be used in future studies. Our next step here at Tier 3 is to conduct some cross-sectional analysis with later stages and see the differences, and if we can have some differences between other groups of early cognitive stages, such as subjective cognitive decline and mild cognitive impairment as well, compared to the healthy controls. All the sensors.
The price and when it will be available to the people.
All the sensors are available at the market. All of the sensors, the Fitbit, the Dream, the Fitbar sensors are available in the market. So there is not a particular cost, but because it depends from the combination that someone wants to do. So if someone wants only the Fitbit and one Fitbar sensor, or wants 10 Fitbar sensors for monitoring ADLs, it depends from the quantity of the sensors that someone wants to use. But it's not very expensive equipment. This was also considered during the focus groups. After presenting the sensors, we excluded those that were very expensive. No other questions?
Thank you very much for this great presentation and also for the manifold questions about this really interesting research project. Our next presenter is going to be Nicola Coley from France. And she will be introducing you to the engagement with a preventive eHealth intervention promoting lifestyle changes in older adults, preventive factors and associations with dementia and cardiovascular risk, which was conducted as part of the 18 months HATTIS trial. Please go ahead.
I'm sure you may be aware, dementia and cardiovascular disease share many potentially modifiable risk factors, many lifestyle-based risk factors, such as physical inactivity, an unhealthy diet, obesity, and hypertension. I think you'll hear a bit more about these factors tomorrow in the prevention sessions. But just the very fact that these modifiable factors exist means that we have an opportunity for prevention, for preventing dementia, and even making small changes on an individual level in terms of these lifestyle factors could lead to substantial public health gains. Digital health tools could be useful for delivering preventive interventions. In particular, they would facilitate rollout on a wider scale if they were found to be effective. And another advantage, of course, is that people can use digital tools wherever and whenever they would like. They don't have to come to hospitals or to study centres to be involved in interventions. However, one of the fundamental problems with digital health interventions is non-usage. So people tend to use them a little bit at the start, and if they're not sufficiently engaged, if the tools are not interesting enough or useful enough, they then stop using them. Also, with digital health interventions, it can be difficult to specify the optimal dose. So if we were asking somebody to take medication, for example, to try and prevent dementia, we would say to them, could you take this medication once a day or twice a day? And all they need to do is think about taking that tablet in the morning. When we're doing lifestyle-based interventions, we already need people to be more motivated to want to actually make those changes. And when we're talking about digital health interventions, they also need to be even more engaged to connect to the intervention whenever they can. And we don't know what the optimal dose is for these kinds of interventions. And finally, we realized when we began the HATTIS trial, actually very little is known about how older adults engage with digital health interventions, particularly in the long term. And we know that in younger adults, that increased engagement with digital health interventions can bring about changes in clinical, behavioral, and biological outcomes. But really, there was very little data about this in older populations. And also, we were interested in knowing if certain characteristics could predict how older people engaged with digital health. So I think the objectives cover what I just said, so I'm going to jump on to the next slide. So this was a secondary analysis of the HATTIS trial. So HATTIS stands for Healthy Aging Through Internet Counselling in the Elderly. It was an 18-month randomized controlled prevention trial. It included 2,724 older individuals aged 65 and older who were recruited in France, Finland, and the Netherlands. To be included in the trial, they had to have 2 or more cardiovascular risk factors or cardiovascular disease. They had to be computer literate, which was defined as being able to send an email or being able to do a simple Google search. And they were free of dementia at the start of the study. So the intervention that we tested was an interactive, tailored eHealth intervention to encourage behavioral changes, and there was remote support from a lifestyle coach, and the participants could interact with the coach via the eHealth platform. I'll show you some screenshots of the platform in just a second. So the primary outcome of the HATTIS trial was cardiovascular risk, and in the primary analysis of the trial, we found that there was a significant, although quite modest, effect of the intervention, and so there was more improvement in cardiovascular risk in the intervention group compared to the control group. And the control group just had access to a very basic static internet platform, which just gave them basic health information. And we also saw that the intervention group had significantly more reduction in their dementia risk scores as well at the end of the trial. So this is a screenshot of the platform. It was quite a basic, visually quite a basic platform, and this was in some respects done by design. We wanted to make it as simple to use as possible. And so what the participants could do once they logged into the platform, was to set health priorities. They could say, well, I'm interested in trying to improve my blood pressure, for example, or my cholesterol, or what I want to do is work on my level of physical activity. And then they could set goals, for example, saying I'm going to walk 5 times a week, for example, for 30 minutes at least, or I'm going to try and eat less salt, for example. And then they could also they could input measurements in the platform. So, for example, they could, if they were measuring their blood pressure, if they had a monitor, they could input those measurements, or they could record how much physical activity they'd done or what they'd been eating. So first of all, we just really looked very descriptively to try and understand how people had been using the platform. So the people in the intervention group, logged in for a median of 29 times during the 18 months of the trial. And in the control group, I think, from memory, they logged in about 10 times. So it was a lot more in the interactive platform. They set a median of 1 goal, and 86% of them sent at least one message to their coach via the platform. But what you can see in the top left-hand graph, well, perhaps you can't because it's a little bit small, but the top left-hand graph is showing you the total number of logins per participant during the trial. And so you can see there was actually quite a lot of variation in terms of how often and how much people were using the platform. And we had some kind of super users on the right-hand side of the graph who were really logging in a huge amount of times. And on the left-hand side, we have people who were logging in only up to about 10 times during the whole 18 months. So there was some variation in terms of how people used the trial. And in terms of the goal setting, the most popular types of goals were relating to weight management. That's what people were mostly setting goals for on the platform. But in terms of the advice and education section, so we provided them with a lot of advice and education via the platform, it was the cholesterol information that they read the most often. But in general, that part of the platform was not all that well used. So to measure engagement, firstly, I should say that we didn't say to participants, we didn't ask them to log into the platform a specific number of times. So they were just able to use the platform as and when they wished. And we didn't give them any recommendations in that respect. So we then, to measure engagement, created a score at the end of the trial. And we basically, we created this score based on the number of logins, on the number of goals set, the number of messages sent, the number of measurements that they entered, and the amount of the advice and education materials that they read. So it was trying to sort of combine both depth and breadth of engagement. And we then split the participants into those who we considered to have low engagement with the platform, those with moderate engagement, and those with high engagement. So first of all, we looked at factors associated with engagement. So we measured a whole host of characteristics, of participant characteristics at baseline. And in the end, there were just 4 that were associated with the amount of engagement with the platform. So the strongest predictor of engagement was using a computer at baseline. So everybody knew how to use a computer, but they didn't necessarily have to be using it. But those who were using a computer for up to or more than 7 hours per week were much more likely to engage with the platform than those who weren't using a computer. Also, people with better cognitive performance at baseline were more likely to engage, as were those who were already working on lifestyle changes or who had short-term plans to make lifestyle changes. And finally, we saw that those living in France and those living in Finland were more likely to engage with the platform. But although it could be an indicator of cultural differences, we also think that could be reflecting motivation because the participants in France were recruited through a prevention centre. Those in Finland were participants of previous studies, whereas in the Netherlands, they were recruited by their general practitioners, and so they were a much more representative population. So then what we looked at finally was we looked to see if the changes in outcome measures were different according to the level of engagement. So on these graphs, the little coloured square that you see on each graph shows you the mean difference in 18-month changes in the outcome measures compared to the control group. And in each graph, at the top, you have a kind of light orange color, which is the low engagement group. In blue, you have the moderate engagement group. And in red, you have the high engagement group. The black line is a confidence interval. And if that confidence interval crosses the 0, which you see in the middle of the graph, that means there was no difference. And if it's separated from that line at the 0, then it means there was a significant difference. And so what we saw, for example, in the top left-hand graph for the Hattis primary cardiovascular outcome measure, that those who were in the high engagement group showed significant improvement compared to the control group, as did those in the moderate engagement group. And there was a kind of dose-response effect. We also saw significant improvements in the more engaged participants for systolic blood pressure and body mass index, and there was a trend also for cholesterol. We saw similar results again for physical activity and a Mediterranean diet score. And then when we looked at the overall CADE dementia risk score, which you can see on the bottom left-hand graph, again, we saw a similar trend for more improvement in those in the moderate and high engagement group. And no difference, for all of these outcome measures, no difference between the low engagement group and the control group. So just to summarize, what we found was that use of a digital health intervention was feasible in a population of older adults. And we saw, as had been shown in younger participants, that greater engagement with a digital health intervention was associated with more improvements in risk factors, so in both dementia and cardiovascular risk factors, and that includes both objectively measured and subjectively measured risk factors. However, I think a very important thing to take away from this work was that there were disparities in engagement. So as I said, our previously our population was really a highly motivated population of individuals. We always find that in prevention trials, and it was even more emphasized this time because people had to be able to use a computer before they could be included in the study. So even within this highly selected population, we already saw that those who used a computer less at baseline were less likely to use the intervention, as were those with poorer cognitive performance at baseline. And so in real-world settings, we think that these disparities could be further emphasized, and because these factors tend to be associated with health inequalities, it's likely that if we were to roll out digital interventions on a wide-scale basis, that they could increase health inequalities. So what we would suggest are that the people who are less likely to engage with the intervention, so in our case it was older people who are infrequent computer users or who had poorer cognition, may need extra support for digital health interventions, and also we might need to consider giving them alternative forms of delivery for interventions, because digital health interventions may not work on a one-size-fits-all basis, and we need to remember to include everybody in our dementia prevention initiatives. And just wanted to acknowledge all of my colleagues who contributed to this work, and all of the members of the HATIS and PRODEMIS consortia. PRODEMIS is the follow-on from HATIS, and we're now working on a mobile health app based on the HATIS intervention. So thank you to all of the colleagues.
Once again, thank you very much for this excellent presentation, which was also perfectly on time. I would like to open up the floor yet again to questions, please. Just a second. Since this is a hybrid event, we need a microphone so that the online attendees can also hear the questions. Could you please come over? Thank you. So please wait with your question until you have the microphone so everybody can hear it. Thank you.
Do you think there is kind of a minimum of engagement below which it doesn't make sense to engage in such a healthcare counseling system? And what do you think is the role of social support?
Thank you very much. So in terms of a minimum amount, so we didn't manage to kind of define a certain cutoff, but what we saw was that the low engagement group at each time had no effect on any of the outcome measures compared to the control group. And I'm trying to think what the cutoffs were. We did look how much they used the platform, and I'll have to look. It's in the paper, but we couldn't define a specific amount of engagement. And the other thing was also one of the limitations that we had was that we only had sort of a measure of how much they did overall, but we didn't know if people were using the platform a bit at the beginning or at the end. So I think we do need to study that question further. And I've forgotten your second question. If you could just remind me, because.
What do you think is the role of social support?
Yes, social support. Thank you. And I knew it was a very important point. So actually, yes, social support is very important. We also did some qualitative research with the participants of our study. So we did some interviews with them after the study, and they all highlighted the important role of the coach. And I think in our previous work with older people as well has shown that there really does need to be some kind of interaction, some kind of human interaction, whether that be face-to-face or just via a platform. But I think that's really, really important. And what we've seen when we've done some literature reviews is that really intervention effects are not sustainable if there isn't any kind of support or supervision for them. So, very important. Thank you.
Hi, thank you very much for the talk. I was about to ask if you did any qualitative research, but you've just answered that question.
Yes.
So my question is, from the qualitative research that you did with the participants, did you get any reasons that people had given for why they did or didn't engage with the platform?
Yes. So the qualitative research, we did two kinds of qualitative research. We first of all asked them why they agreed to participate in the first place. And in general, it was because they said it was to help society and because their doctor had helped them. But actually, when we kind of probed that in a bit more detail, they said they were worried about becoming dependent for themselves and for their family. So that was what kind of spurred them on to take part in the trial. And then in terms of what made them engage, they did say the support of the coach was very important. They kind of said what didn't make them engage as well. So they said that, as you saw, the format of the platform was very basic. So we talked with them about how we could improve that in future work. But again, a lot of the time was they thought they were really trying to help the researchers. So they sort of said, well, we did our best and, we wanted to help you. So I don't know if it's representative of how people would sort of react to that in the real world, but this is what our participants said to us.
Yeah, I just think it's interesting to potentially maybe map that to a behavior change framework, so
Yes.
and see where is it the capacity, the opportunity, motivation, for example. But thank you.
Thank you.
Thanks again for the presentation. Just in terms of any comparisons, maybe with younger cohorts, has there been any done in terms of outcomes, results, or why older people may have not continued with the study as well? Is it because of just human nature or more the digital challenge?
So the only thing that we did compare was, so I said we didn't measure usage over time. For logins, we could look at, we did have dates of logins. And what we saw was that in our population, and it turns out that it's a general pattern in whatever the age is, people log in for a little bit at the beginning and then it just drops off. And that pattern was the same in older people and in younger people, so yeah.
Sepp Köhler from Maastricht University. Thank you, Nicola, for a great presentation. And I really love the HETISH study and the work you are doing there in Podemos. I just wondered, because you showed these differences in engagement profiles regarding background characteristics like motivation and whether people are already inclined to do lifestyle changes and so on. How sure are you that's really the engagement with the HETISH platform and not these kinds of things that is driving your associations?
Thank you. That's a really, really good question. And that was one of our concerns as well. It's something that it's very difficult to measure. The people who were engaging with the platform, those who were just motivated to change their behavior anyway. So when we looked at the changes in outcome measure, we did adjust for all of the factors that were associated with engagement and a whole host of socio-demographic factors as well. But it could be that there is something that we haven't measured and we couldn't control for. But we did adjust for everything that we could adjust for. So yeah.
Excellent, thanks.
Thank you.
Okay, then thank you very much. Our next speaker is Daphne ter Huurne. Nice, from the Netherlands, and she will introduce us to remote semi-automatic telephone-based neuropsychological assessments in memory clinic patients about the accuracy and user experience. Please go ahead, the floor is yours.
Yeah, thank you very much. Well, I'm Daphne ter Huurne. I'm a PhD candidate at the Alzheimer Center Limburg, Maastricht University in the Netherlands. First of all, we'd like to thank Alzheimer Europe that I can give my talk here, and I'll indeed be talking about the semi-automatic phone assessment. So, to give some background, well, as we all might know, within the diagnostics in cognitive disorders, a hallmark within this is the neuropsychological assessment. A neuropsychological assessment are all those neuropsychological tests from memory, language, and so on. So these are the two examples that I gave, but also others. And this can be quite time-consuming and burdensome for some patients or people that need to come to the memory clinic. This can be very stressful in that sense. So an alternative could be the remote neuropsychological assessment. This most of the times requires a computer, a good internet connection, which can sometimes be difficult for the elderly population and people with cognitive impairments. So, again, an alternative for this could be the telephone neuropsychological assessment. This requires minimal technical interactions. In that sense, people won't need a computer or an internet connection. And previous studies already found, positive results on its accuracy and its validity. So what is, the relevance of our study then? We also looked at the automatic scoring of within a telephone neuropsychological assessment. So there were tests done via the telephone. I'll get into that in a minute. We recorded that and we got an automatic scoring from the recording. We did research on the user experience, which is still a bit scarce, done systematically. And we did a fully automatic phone assessment. So next to the semi-automatic phone assessment, we also did a fully automatic phone assessment. So therefore our aims are, well, looking at the accuracy of both phone assessments and also the user experience of both telephone assessments, and we also compared this with the care as usual, so the face-to-face neuropsychological assessment. So just to get into, well, what did we do actually? A researcher actually called the participant who was at home in a quiet environment, picked up the phone, and that's all the participant needed to do, and follow what, of course, the researcher was saying. The neuropsychological assessment contained of some a memory task and a language task. I'll get into that in a minute. And in this semi-automatic phone assessment, the researcher guided the participant through the neuropsychological assessment, while within the fully automatic phone assessment, again, the only thing the participant needed to do was to pick up the phone and, yeah, well, do what the computer voice in that sense said. So there was no researcher on the other end of the line. In the semi-automatic phone assessment, the participant could still ask questions if there were any. In the fully, yeah, that was not possible. Yeah, so from these phone assessments, we did some recordings on two tasks. The grocery semantic verbal fluency task, in which we asked the participant to name as many groceries in 1 minute. And the verbal learning task, the VLT, which is an episodic memory task. So there is an immediate recall trial of 15 words and a delayed recall. And we recorded these tasks, and we got a manual scoring, so a researcher scored these tasks, and an automatic scoring from the recording by the use of speech recognition software. Next to this, we also did a user experience questionnaire on a 7-point Likert scale, in which several topics were addressed, such as satisfaction, did they find it simple, was it conceivable, did they find it comfortable, would they do it again, would they recommend it to friends and family. And these are the topics that we also asked after a face-to-face assessment, so we could compare these two. And for the phone assessments, we also added some questions, so the quality of the sound, whether they missed personal contact, and if they found it pleasant not having to come to the hospital or clinic. For the participant characteristics, just first of all, this is the deep SPA study. This is a whole sample of 145 participants that we included here. We separated them in subjective cognitive impairment. Those were people that came to the memory clinic. But there was no cognitive impairment objectified, and mild cognitive impairment / dementia. And these are the groups in that sense. And already a note, not all participants completed all the assessments, but I'll get back to that in the results. And these are the characteristics real quick. As expected, well, the mild cognitively impaired / dementia group was a bit older and had lower scores on the different cognitive domains and questionnaires, while there was no significant difference on sex, education, and a depression scale. Getting into the preliminary results that we found, we did an intra-cluster correlation to see the agreement between the manual and automatic scoring, and this is what we found. This is for the semi-automatic phone assessment, so where the researcher guided the participant through the assessment. For the semantic verbal fluency task, so the groceries again, just to remind you, this was 0.93, which is quite high, but already noting this dot, can you see it? I hope so. On the x-axis, you see the manual count. On the y-axis, the automatic count. So the researcher listened to it, heard 32 correct groceries, while the automatic scoring only saw 21. So there's a big difference here. There was quite some outliers. So this is already something, to keep in mind. And we also found this actually almost the same for the verbal learning task within a semi-automatic phone assessment. Still some outliers there, but also quite high ICCs. For the fully automatic phone assessment then, here this is for the semantic verbal fluency. Again, x-axis manual, and on the y-axis the automatic count. Yeah, this is 0.83. This is just dropped a bit. While for the verbal learning task, we again saw quite high scores. So, just interruption here. There was a relatively high agreement between the manual and automatic scores for both tasks. And then getting into the user experience, here you see just some descriptive statistics. As I said, it was on a 7-point Likert scale, so the topics or the modalities were scored on from 1 to 7. And as you see, there were 95 participants that completed this, this phone assessment, and it was all quite high. But as you can see, there were 13% that wanted to quit the assessment somewhere during the assessment, and already 39% preferred the phone assessment over the face-to-face assessment. I'm getting into the differences in a minute. And then for the automatic, this is again the descriptives. This is also quite high, the mean, and the standard, the mean was quite high for all the topics. Again, 22% preferred the phone over the face-to-face assessment. 20% preferred the phone over the face-to-face assessment. 22% wanted to quit the assessment somewhere during the assessment. And 27% preferred the automatic phone assessment over the semi-automatic phone assessment. So looking at the comparison, because that's interesting. Comparing the semi-automatic phone assessment with the face-to-face assessment, we saw that there was no significant difference between the simplicity, conceivability, comfortability, and whether they want to repeat the research. We did Wilcoxon-signed rank tests due to skewness of the data. But we saw some significant differences in favor of the face-to-face assessment compared to the semi-automatic phone assessment. We could compare only 56 participants because they had both assessments. And when comparing the face-to-face with the fully automatic phone assessment, we saw that, all questions were actually significantly higher for the face-to-face assessment compared to the fully automatic with the computer. We only could, again, there were 28 that had both assessments. But just wanted to say the medians were quite high, even though there were significant differences here. Then comparing both phone assessments, on simplicity, comfortability, whether they missed personal contact, and found it pleasant that they didn't have to visit the hospital, those were equally. There was no significant difference there. While for, as you can see, satisfaction, conceivability, whether they want to repeat the research, whether they would recommend it to friends or family, this was higher on the, significantly higher on the semi-automatic phone assessment. While the quality of the sound, this was the other way around. So the quality of the sound of the automatic phone assessment was better than the semi-automatic phone assessment. And again, here you can see the medians, which are still quite high, even though there were some significant differences. So, concluding remarks, again, there was a relatively high agreement between the manual and automatic score, and participants were generally satisfied on all different modalities. But some discussion points here, again, for some cases, the automatic scoring needs improvement. There were some outliers, and this could be due to the automatic speech recognition. People could talk too fast, so in that 1 minute, someone names too many or too fast those groceries, or had a really soft speech or a dialect, which is quite difficult to recognize by that software. So in a way that needs to be improved. For the user experience, most measurements were done during the COVID pandemic. So you can imagine that people liked that they could stay home. So that's something to keep in mind. Some future analysis would be what is the differentiating power of this telephone neuropsychological assessment in differentiating people with subjective cognitive impairment and people with mild cognitive impairment or dementia, or maybe even the 3 groups. And we recorded the tests, so we could maybe extract speech and linguistic features from those, which can give us a little bit more information and maybe can add to the differentiating power on the phone assessment. So that would be future analysis. Why did we do all this? We want to implement it. If this could be implemented. It's based on a telephone connection. It could either be landline or a mobile phone, doesn't matter. You could implement it within clinics to easier follow people over time. And maybe when you're like, oh, yeah, then bring them to the clinic, or in medical deserts, so people that can't go to the clinic that easily. And you could maybe use it as a screening for intervention studies. Yeah, and that was my talk. This is my team. I really want to thank them all. It's from the Deep Spa Consortium, and thank you for your attention.
Thank you very much for this very concise overview of your work and these interesting findings. I see there are already hands up in the air. People are quite interested in this. Please.
Hello. I was just wondering, this is great if the people that you're assessing, main issues are verbal issues. Yeah. But this is not going to pick up gait, this is not going to pick up issues around maybe seeing things, it's not going to pick up lots of other things. Yeah. And, you know, looking at my own husband's dementia, his verbal skills are still probably higher than the majority of the public. Yeah. But there are other issues that if this had been done on the telephone, they would have just passed him saying there's nothing wrong. So I wondered, where does this fit into the whole scheme of doing assessment? Because on its own, for me personally, it doesn't seem enough.
Yeah, thank you very much for your question. It's a really good question. This is something, of course, I think it won't replace the full neuropsychological assessment as we know it, because indeed there are individuals that verbally are great, but in some other cognitive domains, are impaired, and that would be lost. But it could be a way, and I think then if you would implement it in clinics, there should be a call with a clinician beforehand to also see how it's going, and it could be kind of something. But and I think if you do that, so have a conversation with a caregiver or with the person themselves. And they were feeling, but verbally it's going great, but these things are not great. Then someone should come to the memory clinic, of course. Very good point, because that's something you can't do over the phone, of course. Very good. Thank you.
Hello.
Hi.
Did you call them, or did they call you? I mean, were the calls incoming or outgoing? I'm just trying to figure out if they were prepared for the call, or was it within a pre-assigned time? But still, there's a difference. Being, caught on guard or off guard.
Of course, thank you. Very good question too. I first made the appointments with them, so they were prepared, and I said, please, in a quiet room. Don't use pen and paper. We hope that they did it, of course. But so they were prepared for the call, and they knew what was coming. They already had a face-to-face assessment beforehand, so they kind of knew, some of the tasks that we did. So they were, and that was also something that we did some open questions. I didn't have the time to show you this, but that was something that we also saw. People were like, I would do it now, but for the first time, if someone would do this for the first time, I think that would be too hard and too stressful. So some people said that too. Thank you.
Last but not least, our next presenter is going to be Fanny Monet from Brussels, speaking about developing an advanced care planning website for dementia, integrating a user-centered approach and patient and public involvement. Please, the floor is yours.
Thank you. Hello, everyone. Can you hear me correctly? Okay, great. There we go. So my name is Fanny Monet. I'm a PhD student at the end of Life Care Research Group at the Vrije Universiteit in Brussels. And so today I will talk to you about our experiences with using user-centered design and patient and public involvement together to develop an advanced care planning website for people with dementia and their family caregivers. Oops. The big one? Oh, that one. Yeah. There. It's my first in-person conference, so that's... So first, yes, what is advanced care planning? Well, it's been defined as an ongoing process that allows people to explore and identify their values and to define goals and preferences for future care and future medical treatment. And it really involves people discussing these preferences and their wishes for future care with both family and healthcare providers. And part of this can be to appoint a proxy decision maker or to document these preferences in advance directives, for example. And this process is really important for people with dementia and their families because it allows them to discuss their wishes as they lose decisional capacity throughout the dementia trajectory. But actually, we see that advanced care planning remains quite infrequent among people with dementia, despite the fact that it's recognized that it's an important process for them. And this can be due to the fact that they experience several specific barriers, such as emotionally difficult conversations, or a lack of information on what advanced care planning is and what it can or cannot achieve. Or they might also just lack guidance on how to conduct advanced care planning conversations. And we see that current advanced care planning tools are developed for other illnesses than dementia, so for example for cancer, or they're targeting health professionals and how they can bring the subject to their patients. And so that's why we decided to develop an advanced care planning website for and with people with dementia and their families. And so from the beginning, we really wanted to involve people with dementia and their families throughout the whole process. And there's actually a wealth of literature on the importance of involving people with dementia and their caregivers throughout research and eHealth development. Here are some example papers. I'm sure some of you in the room are familiar with them. And so to do this, we went two ways. First, we decided to go for a user-centered approach, which is really characterized by an iterative development and design process, going through rounds of testing and of development. And this is a method that really focuses on end users' needs and wants in each phase of the development process. And it's particularly useful to study technology usage. And then we wanted to combine that with patient and public involvement, also known as PPI, where we actively work in partnerships with people with dementia and members of the public to carry out research. And so to combine those two approaches, we based our development process on a validated process map on how to develop web-based decision support interventions for specific audiences. And this is really characterized by two phases: a content specification phase, where we have a look at the evidence base that is already out there, and we do a user needs assessment, which is then summarized together, and then we move on to the creative design phase, where we work in iterations and prototypes to develop, in our case, the advanced care planning website. And this process is really characterized by the involvement of 4 different groups. A project management group who is like a core development group who has editorial control on content and design decisions. And then we have a project group, which is composed of members who are there for their scientific knowledge and that can critically contribute to the content and the design of the website. An advisory group is also composed, and in this case, it's composed of members of the public or relevant stakeholders who have more practical knowledge and can also really critically contribute to the content and design of the website. And finally, we have a technical production group or an IT or developer partner who has the particular skills to develop the technology. And this is a process map based on Elwin and colleagues. So this is how it, I hope you can read it, but I will go through it. This is how we translated it to our project. We did a content specification phase with different literature reviews and seeing what advanced care planning content is already out there on Dementia Association websites, and we also did some focus groups to see what needs would be for this website, and we summarized all this. And then we were able to move to an initial concept of our website, and then we had 4 iterative rounds of user testings where we slowly built the prototypes. So first we had a prototype that was solely the structure, layout of the website. Then we integrated a information part of the website. In our 3rd round, we integrated a communication part of the website. And in our last testing round, we tested the website as a whole. And so we involved people with dementia and their family carers first in the testing of the prototypes with testing participants and with the advisory group that I just talked about throughout the whole process. And so to go a little bit more in detail on how we involved them, our testing participants were people with dementia, family caregivers, and diets testing the website together. We involved new participants at each sprint, so sprint or round, testing round, so 4 times. And we used a think aloud method where we asked them to use the website and to give us their thoughts throughout the process, what they liked or disliked, or any difficulties they might encounter. And we also, at the end, gave them a usability questionnaire. And in our last testing round, we also did a semi-structured interview. And then on the other side, we involved our advisory group with representatives of dementia organizations in Flanders, people with dementia, family caregivers, and palliative care experts. We met in 6 instances through initial concepts, all the testing rounds, and the final meeting at the end of the development process. And there we had a more open-ended meeting with opportunities for feedback on the different prototypes, either in online meetings or through email if people were not able to attend meetings. And so here I just put an overview of what the website can look like through the different rounds. The first one was really basic, and then it slowly gets more elaborate. And so, like I said, in the end, we have information about the website, about advanced care planning on the website, with a definition of what advanced care planning is, what its added value is, and as well as a glossary of complicated terms that can exist in advanced care planning, and frequently asked questions. We have tips for communicating about advanced care planning, both from the perspective of the person with dementia and the family carer, as well as how to communicate about advanced care planning with health professionals. And we've also included videos, testimony videos of people with dementia and carers who've already gone through the advanced care planning process and can give tips. And we give access to 2 interactive tools that can help reflection about advanced care planning. And we also included a few accessibility features. There is the choice between 4 font sizes, a contrast option, as well as a read aloud function. And so a few of our successes and challenges to finish. Through combining PPI with the user-centered approach, we really got relevant, insightful, and valuable feedback that informed the development of the website. It helped us identifying some content that was missing from the website initially, as well as technological issues. And then in the end, the website was seen as user-friendly and relevant. And we now have a website that's ready for a larger scale evaluation and to see also what effect it has on advanced care planning engagement. We did notice that we ran into recruitment challenges in the user testing phases. This can be due to the COVID-19 measures that were in place at the time. Our PPI meetings were completely online, and we also had some limited access to our target population with the measures. So in the end, we had a lot more family caregivers than people with dementia included in our sample. But we hope to remedy this in our larger scale evaluation. And that's overall how we developed our website. Thank you for your attention. And I'd like to thank our team on the project, as well as all our participants and the members of our advisory group. Thank you.
Thank you very much for this great overview of your interesting work. We still have time for questions. And
My name is Peter Kolominski from University of Bavaria. I'm a neurologist, and thank you, Fanny, for this very great presentation. I think advanced care planning in dementia is absolutely underestimated in Europe. We are mostly focusing on cancer patients, but not on dementia patients. My question is, do you plan to develop your excellent system to have an individualized advanced care planning in future, so people can put in data and they can get out, let's say, a short report, web report, and present it to the GP or to a special institution so they can plan it?
Mm-hmm. So, like I mentioned, well, I didn't go that much in detail, but we do have 2 interactive tools that help with reflecting about advanced care planning. And there we have one tool that helps. It has like a few questions where we can type in like our thoughts about advanced care planning. And there's also a kind of card game that's based on the Go Wish cards, which is a tool that really helps with reflecting about end-of-life care and advanced care planning. And all those tools can be saved and printed, so they can bring them with them to their appointments.
Just curious, why website while the latest fashion is smartphone apps? Just curious.
Yes. So
because of the age group of the users, or what?
So there's different considerations that we can take into account. We went for a website because so we see that often the preferred source is healthcare professionals for this kind of information, but there's healthcare professionals are really busy and they might not have the time to really take the time to go through the process of advanced care planning or to go through all the information. And for us, it's really important that it's an ongoing process. So we tried to take it out of the health professional domain and bring it into the family context, adopting more of a public health approach. And with a website, this can be used at any preferred time or at any preferred place. So that's why we decided to go with a website. Yes, a website as compared to an app, it's easier to update if laws or legal frameworks change, and yeah.
Yes, you might have mentioned it, but what's the best moment to start the advanced care planning? Is it directly after the diagnosis or furthermore in the process? Do you have any information about that?
Yeah, so that's a tricky one because, of course, it's a little bit of a sensitive subject, especially for people with dementia. We see that often they want to live in the now and not think about the future. So ideally, it's as early as possible, but it really needs to be at the time frame of the person with dementia when they're ready.
Yeah, so I have two comments. So the first comment is it's just a great example, I think, of how you can include people of the public and people with dementia and carers in research. And then my question was, building upon the previous question, do you have any ideas on how to introduce this website or this topic to people who are affected by dementia? Mm-hmm. And at what point would that be?
Mm-hmm. Yes, so that's also why we included in our advisory group also representatives of dementia organizations who can also advertise for this website, and they can be introduced by dementia organizations or also by health professionals who can introduce the website and say, have a look at this website, see what you think, and we can talk about it at our next appointment. Thank you.
So I started clapping because we have arrived at the end of this session. Nevertheless, if you have any follow-up questions to these brilliant presenters, please feel free to do so during the break. I would also like to highlight that there is another session focused on warm technology organized by Alzheimer Netherlands on Wednesday. That's starting at 1 o'clock. It's not in the program book. It's going to be on the banners in front of the doors. So if this topic continues to spark your curiosity, please do check out this session. Thanks again for the very interesting exchange, and I wish you an interesting conference.